Hello and welcome to the Imaging Wire Show. My name is Brian Casey and I'm managing editor of the Imaging Wire. Got a great episode for you today. Our topic is an introduction to DeepHealth. And our guest is Sham Sokka. He is Chief Operating Officer and Chief Technology Officer at DeepHealth. Sham, thanks for being with us today. Can you tell us a little bit about yourself?
Yeah, thanks, Brian. Good to be here with you. Yeah, Sham Sokka, have been in radiology for better part of my career. Actually did my PhD in MR. I spent many years in the imaging side of the business, imaging modality side of the business. And then the last 15 years have been on the informatics and software side of the business and joined DeepHealth from Philips just last year. So really excited to be here and chat with you about what we're doing.
All right, very good. Well, we're going to dive right into it. So DeepHealth it's kind of a new brand in radiology, but it is comprised of some components that have been around for a while. And you guys made, I think you launched earlier this year and you made a pretty big splash at a couple of meetings, ECR and HIMSS. Can you talk a little bit about the formation of DeepHealth and how the company came together?
Yeah. DeepHealth is a fusion of multiple, pillars of what I would call radiology, right? So one pillar is the RIS and the radiology information system. So it's the clinical data, the revenue cycle around it, and the management of operations of radiology, plus a PACS solution. These two, formerly called eRAD, and those two are still a very strong pillar of the business. And then RadNet had acquired several AI businesses in multiple clinical areas, from breast, prostate, and also in the lung cancer screening space. And so DeepHealth is a fusion of all of these businesses on top of a cloud-based operating system, right? A cloud-based infrastructure that we're using to really bring all these businesses together. And so we launched an RSNA with the real goal of bringing AI-powered informatics, both clinical and operational, into the market. And we're initially focused on outpatient imaging, which is where a fusion of these things can really have immediate impact. But obviously, we're also seeing some of the use cases in health systems and in academic medical centers as well.
All right, very good. So what can you talk a little bit about DeepHealth's relationship with RadNet? So RadNet is one of the larger imaging services companies in the U.S. And
yeah.
So I guess we'd call them your parent company?
Yeah, exactly. So DeepHealth is 100% subsidiary of RadNet, and as of this year, we're a separate reporting division. Previously, RadNet had reported just the AI businesses as a separate unit, and for the first time in 2024, we put all of our technology business under a digital health business kind of categorization, and we report that separately. But it's 100% owned entity of RadNet. And there are some really interesting benefits to that. Part of that is being able to have an environment for validation and testing. But the DeepHealth business is really focused on external customers.
So what are some of the challenges that are faced by radiologists that you think that DeepHealth is addressing?
Yeah, look, I think the core challenge, I would put it into three different areas, right? One is the continuous management of the patient, right? Radiology is moving into an environment where we're not just transactionally seeing patients, but we're seeing them over and over again connected to care pathways. So there's the patient engagement component. And we think we can have a very significant impact on that. The second major challenge is the workforce challenge. Everything from, the guys that manage the center to managing the front desk to the contact center to schedule patients to the technologist shortages to the radiologist shortages. So the end-to-end workforce challenge. And then the third piece is the notion that we're in a universe today which has just way too many separate IT integration points, right? The data is flowing around everywhere, and we keep talking about AI, but we don't have data consolidated in one environment to operate on it and then to affect an outcome. So with the DeepHealth OS, which is our sort of primary product, one of the core things is to bring these three challenges, into the foreground and build solutions that simultaneously address these at once.
Okay. And so you mentioned at the beginning that DeepHealth also has PACS and RIS.
Yeah.
And so I guess that makes you a little bit different from some of these other AI companies where, they've just got the AI, either the point solution or the platform, but it sounds like you've got PACS, RIS, and you've got a platform, and you've got some point solutions. So that kind of a whole soup and nuts.
Exactly. And that's what we were talking about, right? To really address the end-to-end radiology problem, we need to be able to bring these pieces together, right? So RIS, well, first of all, there's not many players that are both in the RIS and the PACS game. So that allows us to kind of get the core platform. And then we're able to inject the AI right into the workflow, right? And so I think that allows us to be stronger in terms of bringing an AI to market, but it also strengthens the RIS and the PACS because we're able to now inject AI into the right places into the workflow.
And again, your products are being used in RadNet, which is, a pretty large environment. And so that's probably a great opportunity for you guys to kind of see how things are working.
Yeah, in RadNet, but also externally, right? I think, our AI products are, are used in more than 100 customers externally from RadNet.
Outside RadNet, yeah.
Outside cool. RadNet. And our RIS PACS is used externally with 200 other customers besides RadNet. So
right.
that experience also comes in so we can build a more common solution for the industry.
Let's talk a little bit about some of your lead products. So if we focus on AI for right now, you came up with the branding SAIGE, SAIGE, to cover some of the AI solutions. Can you talk a little bit about some of those?
Yeah, the core of our AI mission is to do population screening, right? So all of our solutions, mammography, lung cancer screening, as well as prostate cancer screening, our ambition is not just to provide the asset to make the reading easier, with higher quality, with better outcomes, with lower recalls, but we also are attaching it to other solutions that enable the whole program. For example, things like compliance in mammography, right? Tracking solutions in lung, right? Where we can actually also, year to year, manage their progression and their surveillance. So our core offering there is the sort of idea of AI for population screening. And the lead product, I would say, is mammography. This is our bread and butter. And we, in Europe, have a very strong lung cancer product. And then what I would say is on the horizon is the prostate cancer screening, because it's an emerging space. And we think leveraging experience in mammography and in lung, we can help also scale out prostate cancer screening as a way to drive the industry, right? As radiology has, we think, quite a big role in prostate cancer screening.
And what are the names of some of those products?
Yeah, so we've unified the brand under SAIGE. So SAIGE Breast is our mammography product, SAIGE Prostate is our prostate product, and SAIGE Lung is our lung product. Formerly, our lung product was known as Aidence, and formerly our prostate product was known as Quantib.
And these are companies that were acquired in the last few years.
That's right. That's correct. That was acquired in the last few years. We've enriched it, integrated it into these sort of more program-based screening, solutions, and enriched it and integrated into these sort of workflow tools at the same time.
So what was the rationale for focusing on screening? I think that, just me personally, some of the most exciting research that I'm seeing coming out has to do with screening, but can you tell me why DeepHealth decided to really kind of focus on that?
Yeah. The core, a big part of our mission is really to enable access to imaging, and particularly that sort of circles around outpatient imaging, right? And if you look at outpatient imaging, the largest volume and vector is really this notion of screening and well imaging. The majority of outpatient imaging is targeted at the masses to be able to rule in, rule out disease, but also particularly the cancer screening workflow. And what's really fascinating about screening is it's a place where radiology is being asked to take ownership of the patient, right? We're just not a pass-through service. We're actually taking ownership like we do in mammography, right? Because primary care is too busy to manage everything. The power that we can say in radiology is, hey, we will take it for you. We will take mammography. We will take lung cancer screening. We will take prostate cancer screening, and we will manage them and monitor them on a year-to-year basis. And when there's an escalation, we'll bring them back, right? And do the proper escalation. So we think it's a care paradigm change. Now, in order to do those volumes, you need,
Need some help.
You need help.
Yeah, that's a lot of screening is a lot of volume.
Exactly. And so that's where we think AI can have a huge impact. So there's the resource issue, but then there's also the issue that I want screening to be, mammography, take mammography. I want it to be as good in New York City, right? I want that level of quality in the top academic center in New York City to be in, in a rural village in Nebraska, right? And one of the ways that AI can really do that is it can provide that standard level of quality across. And that's what we've seen in our mammography AI particularly. And so, now I feel more confident that we could we could put a mammogram in a Walmart and get the same level, or support a patient to get the same level of quality as they may be in an academic medical center.
Right. Wow. That's a great point. Great point.
Yeah.
And so how are some of your solutions being distributed right now? How are people getting them?
Yeah. So we are doing a couple of different things. We're obviously selling directly in a select class of customers, outpatient imaging, large outpatient imaging, where we go direct. We are also working very closely with AI aggregators. So folks like Incepto in Europe, but also other aggregators in the US, et cetera. So that's one common mechanism. And then I think a third area is that some of our AI is deeply integrated into other people's portfolio, whether it's a PACS portfolio or an imaging system portfolio, right? So, for example, in Europe, we have such a relationship with GE in some of our AI applications.
So there's a lot of different ways for your algorithms to kind of get used.
Yeah.
And so what do you hope the impact of your technology will be on patient care? Enabling rural areas, maybe access with lower access to care have for both folks there to have the same level of care as maybe an urban area. Is that kind of what it's all about?
It's a big part of our mission is about access, and access at the highest level of quality and outcomes. When I started in 2000, right, and we were working on hardcore MR technologies, we were talking about a scan that was $1,500 to $2,000 per scan, right? We're now doing prostate cancer screening, MR based, for $250, right? With AI assistance that can be done. And remember, prostate is one of those things that, again, you needed a lot of specialized technologies 10 years ago to do. Now we can do that, without specialized coils, without, specialized preparation, with an AI, an acquisition that's 8 minutes or less. And that now becomes much more accessible from a price point perspective, from tolerance perspective, right? If I had to put somebody through that kind of, preparation, it wouldn't happen, right? So we're now moving to a point where, I hate to say it this way, but an imaging study of that kind of quality can be done as for a urologist, like he would order a PSA. That's powerful. And now we completely changed the care paradigm because we just moved specificity, sensitivity for prostate cancer screening from, PSA, which is horrible, let's put it that way, to something that is 90%, on the acceptance and the outcomes rates, right? So I do think, and that means we're going to find cancers earlier. We're seeing that as well in the lung cancer screening program in the UK. We've actually starting to see data that we're actually stage shifting, finding patients one stage earlier, right, in mass populations. So access, real outcome change in terms of things like stage shift, and convenience, right? Because we can bring the cost and the protocol to make them happen easier. It's going to just be convenient that people are just going to do it.
Do you see, so prostate screening is a really interesting topic because, as far as I know, it's not really advised by guidelines, partly because PSA is, as you mentioned, is such an imprecise test. Yeah. But now with all the studies on MR being able to segment people and combining that with PSA levels and then adding in AI, I mean, do you think we're going to get to the point where prostate screening becomes a guideline-directed test like some of the other ones?
Yeah, we think that's a possibility. Part of what we're doing now is in our program that's more of a patient charged study where we've ramped it up now on the RadNet side. We've ramped it up in some of our centers, and the idea is to use that to accumulate data to show that value, right? So just like we've shown with real world evidence the benefit of Mammo AI, we want to be able to do something similar for both prostate cancer screening and the benefit of AI to that, right? In terms of real outcomes. So we think that's the case, but we're going to be doing the real world data, acquiring the real world data to come to that conclusion as well.
Okay, great. So if we can kind of go to like the 30,000 foot level for a minute, and talk a little bit about the potential of AI and the arrival of AI in healthcare and radiology. Do you feel like, a lot of people say, well, Guy, we're not really getting there. AI is not being used at a level that we kind of wish it were. Do you feel satisfied with how AI has progressed in radiology? And if not, like what needs to happen to get there?
Yeah. Am I satisfied? Of course, we're not satisfied. I think the industry is not where it could be. Are we getting more savvy? Are we maturing? Yes. Right. When we first started, a lot of it was about productivity. We're realizing that it's not only about productivity, right? It's about things like what we just said, quality, offsetting, the resourcing problem across. So there's a programmatic benefit to AI, not just an individual, I make a rad better, right? We're starting to learn those kinds of use cases. The second thing I think is that when we first started with AI, we took a broad spectrum of the problems we were trying to solve, and it's natural in innovation. And you're not always going to find the right problem, right? And I think we had a little bit of that as well. And we're now converging on big problems like screening, right? And then the third piece is the business model, right? Which, it kind of goes with that right application. But right application, right business model, I think is also a key. And we're starting to see that we have to think very creatively about how to monetize that to keep it sustainable, not to necessarily try to create a whole new cost to the system, but how do you shift the monies to keep it sustainable? And we're starting to see that.
And what are some possible solutions to that? Do you see like patient payments or things like that?
I think patient payment is one. Patient, in this case, it's an interesting example. Patient payment as an escalation to coverage, right? I don't think we're suggesting that patient payment is the end all be all, but what we need to be able to do is when an AI asset is increasing the standard of care, it needs to get covered. And so in that gap, what we've said is let's charge patients, right? Because there is value and, for example, better detection, lower recall rates. But what we're now also seeing is, as we've shown that data, right? Different groups, employer groups, state groups are starting to cover those. We're seeing that in our own example. And so we see it as a bridge to coverage, right? And I think that's what we have to get creative about. How many of these AI assets, when we do see meaningful improvement in the standard of care, how do we drive to get coverage, right? And this is where I think I struggle with the notion of making a RAD faster. That doesn't create new money in the system.
It just makes them work harder.
It makes them work harder. And we're then, thinking about, hey, do you keep the money or does the tool keep the money? And you get into that dynamic. But when we raise the overall standard of care, and if I look at mammography, it's a great example. We went from 2D to Tomo. It wasn't that Tomo was reimbursed at the same level. We showed better outcomes, and so therefore was reimbursed better, right? CAD came, right? And again, it got reimbursed because it was a better. And AI is better than CAD, right? And again, we're seeing the data to show that. And now that needs to get covered too. And we're in that gap, right? And I think that's happening across multiple specialties in the industry. And where we've shown value, we've gotten coverage, right? It's how you fill the gap, right? We make it sustainable in the gap.
So I guess we just got to prove that value. So Sham, on that point, can you talk a little bit about RadNet's program where they actually are having patients pay for the use of AI?
Yeah, so happy to. So what we're doing at RadNet is we've put together a combination of AI workflow tools and additional radiologist activity to create a proposition that we called Enhanced Breast Cancer Detection, EBCD for short. And what that solution is it includes both an AI as an assisted reader. And when there's a disagreement between the assisted reader and the AI reader and the primary reader, a third radiologist is brought in to essentially provide a interpretation, but also to kind of discuss with the primary reader, conference with them to come to a joint conclusion. Often that second reader is a expert, is a recognized expert. And so what happens in that workflow is a percentage that's less than 5% get that second that second radiologist to come in. So that entire proposition, right, that assurance that you have really multiple eyes and the best eyes looking at your mammogram is what we sell as EBCD. And so there's some confusion in the industry, which is we're just, we're charging for AI, right? And the reality is we're charging for this integrated AI plus the safeguard review, right? And that's really that's what's driving the better outcomes, right? The increased cancer detection rates and the reduced recalls. And so that's charged extra to the patient. And then the data that we've accumulated, we've now shared it with different groups. And in fact, some of the groups that in the RadNet catchment area have actually said, we'll cover it, right? So some employers have said, okay, we think the value is so good that we'll cover that extra $40 for our patients.
Oh, and right? So then the patients aren't paying anything at all.
Patients aren't paying anything at all. As well. Got it. So just to kind of complete the thought, what we're doing there is we're seeing that as a solution, patient payment between coverage and kind of and actually once we now have shown the outcomes, it's to cover the gap to like get
a bridge to get to there.
A bridge to get to coverage.
Yeah. Hey, are you seeing good patient uptake of that? Of the EBC?
So absolutely about 1 in 3.
Okay.
Right. Oh. And then in some neighborhoods, we see it can be, 60 to 80% even. And it turns out that it has nothing to do with socioeconomic status, and in fact, very little to do with it. But it turns out it's a lot more about education, right? Do people understand what they're paying for? Do people understand the current standard and what this standard is? So what we've realized that the education piece of that is super critical, right? As you can imagine, right? Whereas an AI that might just be benefiting the rad or making the rad go faster. You don't have to do the same level of education. When now, if you're trying to really get the patient to opt into something, we have to be very clear to them on what the benefit is.
And I'm thinking that could be a really nice marketing angle for the imaging provider if they were able to offer a service like this versus somebody down the street and that doesn't. And then patients might want to go back to that provider.
Yeah, absolutely.
To get that.
So if we look at again, many of the patients that at many outpatient imaging centers are recurring patients, right? And so they're some of the most important pieces is that care continuity. So we absolutely think that having such a service also creates that stickiness, the desire to want to come back, which we hope also increases compliance over time.
So coming up in the year to come, what can we see from DeepHealth? What new clinical areas do you hope to get into? What can we see happening?
Yeah, I think the first piece is really us getting putting these solutions together so that they're seamlessly operating with each other, right? The risks, the PACS, and the AI becoming the OS, right? The true operating system for radiology. And so we're spending a ton of time doing that, bringing that together, and people will see those use cases as we start to bring them into market. And that's things like, as we go to drive a screening program, everything from how do I optimally schedule the patient to how do I track them to make sure they come in, to the actual protocoling for the study, to the interpretation and so on, right? Bringing the whole thing together. So we are really focusing both in our mid-year release and then our end-year release on delivering pieces of what we call the OS, right? The integrated proposition. And we think the integrated proposition is going to bring a lot more value to deliver these programs, because it takes more than AI to deliver a successful population screening program.
Yeah, very good. All right, well, something to look forward to for the rest of the year.
Yeah.
All right, well, I'd like to thank Sham Sokka of DeepHealth for being with us today. Sham, that was a great discussion. Thanks for being with us.
Pleasure. Looking forward to talking with you and others about what we're doing.
All right, very good. Signing off for the Imaging Wire, my name is Brian Casey.